Dr. James Bullock here, Orthopaedic Center of South Florida, sports medicine and shoulder surgery subspecialist. And today I'd like to take some time to talk with you about shoulder arthritis and in particular surgical interventions that we do for shoulder arthritis, two main different kinds of shoulder replacements. So shoulder arthritis or osteoarthritis is when there's wear and tear of the cartilage, which lines the bone of the ball and socket joint of the shoulder. At times, patients can have prior injuries that cause damage to the cartilage and there's wear and tear over time, or I have a lot of patients that don't have a specific injury episode history, but based on the jobs they do or sporting activities they're involved in, over time the cartilage wears down. When the cartilage wears down, it exposes the bone that is underneath the cartilage, and that has nerve endings in it, and it can cause significant pain. There are usually other changes such as inflammation of the joint lining tissue and sometimes wear and tear of the tendons around the shoulder, which contribute to pain as well. As much as possible, we try to manage these problems with non-operative measures such as physical therapy, which can be quite helpful, and anti-inflammatories if it's appropriate for the patient, and activity modification. Sometimes injections, whether steroid injections or platelet-rich plasma injections, different options for patients. But ultimately, if the arthritic changes are really severe and the patient has a lot of pain which has not responded well to these measures, also a lot of these patients have functional limitations, so they can't do simple things like reach into a closet to get something like a hanger off of a rack, reach into a cupboard to get food, for example. And one of the big drivers for patients actually deciding to come in and get treatment is they can't sleep because the shoulder hurts a lot and they toss and turn at night. So two main kinds of shoulder replacements I wanted to discuss. One is a standard anatomic total shoulder replacement, and the other is called a reverse shoulder replacement. So if this is a shoulder model, here's the ball, and this is the socket that's hidden in here. We make an incision and we get down to the front of the shoulder, make a small incision along the course of one of the front rotator cuff tendons, if it's intact. In this particular case for anatomic, it would be. And then we get to access the ball of the shoulder. We make a resection, that is a cut, to remove the arthritic portion. And then what we're doing is we're putting an artificial ball and socket in. So in this model, for example, this is a short-stemmed implant. We would have made the cut to remove it. We would have prepared the canal of the bone to get this small stem in, and then we put an appropriately sized cap or humeral head prosthesis on. And on the socket side, what we do is we try to put a resurfaced socket, which is a special, very high wear-resistant plastic-type material called polyethylene component in. And that becomes the artificial ball and socket portion of the joint. And so when the patient is moving now, it's not the arthritic parts rubbing against each other, but these resurfaced areas. Of course, we reattach any soft tissue and tendons. So that's one kind of a shoulder replacement. So with the standard anatomic replacement, we have lots of options for how to do this, meaning the kind of implants we use and the techniques. So I have a lot of patients actually mid to late 40s and 50s who are very active, still involved in sports, or they do labor intensive work, and they've had prior significant shoulder injuries and they have osteoarthritis at an early age. So we're able to do what's called a stemless anatomic replacement, or the shorter stem, which I've shown. So for example, the stemless one, what we do in doing that is we take away less bone from the upper part of the humerus, and we essentially have a much smaller implant which preserves the patient's native bone. This is good because the recovery can be easier, and also if you're doing this on someone who is quite young, in their late 40s or 50s, and they have a long lifespan ahead, if they have to have a revision down the road, hopefully decades down the road, then the revision will have more native bone available and would make that procedure easier. So the other kind of shoulder replacement is called a reverse shoulder replacement. And people always ask, well, what does that mean? Instead of the prior model I showed where we put a ball on the ball side and a socket on the socket side, a reverse replacement flips that. So we actually put a ball component on the glenoid or the socket side, and we put a socket type part on the humeral head or the ball side. And the reason that we do this is, like an example which I'll show, is the patient no longer has a functional rotator cuff. So even if we put in a standard ball and socket, their function is going to be poor. So the reverse replacement changes the center of rotation, and it allows the deltoid muscle, a bigger muscle on the side of the arm, to take over. These patients we're doing this for oftentimes come in and, I ask them to raise their arm and they can't. Their arm is stuck at the side. And by this mechanical change, we address the poor function, and they're oftentimes in their first 1 or 2 post-op visits able to raise their arm overhead. And the replacement, resurfacing the worn parts of the cartilage, addresses the pain, but the mechanical changes helps to address the functional limitations. So these are our major surgeries, but we oftentimes now can do these even in the outpatient setting, and the patient goes home the same day with the appropriate patient, and the outcomes are generally excellent, of course, if you choose the right candidate for it. So here we go. I have a patient that I'm seeing for non-arthritic condition in the shoulder. And here you have the humeral head, and this is the socket called the glenoid. And this patient has good joint space between the ball and the socket. Here is another patient that I have upcoming for a shoulder replacement. And you can see that the space between the socket and the ball are completely obliterated. And if we look at this side view with the arm out to the side, this kind of should be the golf ball on the T view, and you see there's really no space between the socket and the ball, and there's excessive wear of the back of the socket. So here's a patient that came to consult with me. She had undergone a rotator cuff repair in the past elsewhere, and it was not successful because of the severity of her tear, and she had difficulty raising her arm and a lot of pain. So this is a candidate for the reverse shoulder replacement, because what's happening is you can see the ball is higher than the socket, and when we look at her MRI, you can see it's actually more severe. Here are her prior rotator cuff repair anchors from her surgery elsewhere, and the ball is escaping above where the socket is because the rotator cuff tendon is not intact. So what we did in this particular case, before surgery, we got a CAT scan for some more evaluation and for 3D planning. And we did a reverse shoulder replacement on her, which I'm showing you here, where we put a ball on the socket side and a socket on the ball side. And she has actually done really well. I actually had to do it on both of her shoulders, and she has perfect, excellent overhead motion.